Nice. So I think on that note, I'm just going to introduce you to everyone, and then people will just have to join in the background as we go. So yeah, good afternoon, everyone. Welcome to this episode of the Family Medicine tutorials. And we're really excited to have Dr. Nash, Jenny, joining us this afternoon. So Jenny Nash is a district family physician, as you can see on the slide, and she's working in East London and has been for the last couple of years. And she's a good friend. She's supported us in the past at Madwaleni and continues to do really cool work in and around East London. So Jenny, you've been involved in PMTCT training since the new guidelines have been updated. Is that right?
Yes, that's correct.
Yeah. So Jenny's got some cool cases for us today. Some stuff that's based on some of the training that she's done with is it still called NEMAT nurses training?
Yes, the broad concept is called NEMAT, yes.
Cool. So yeah, HIV PMTCT can get our brains into a little bit of a spin. So hopefully these cases will help us to have an approach as we deal with these kinds of cases in our facilities. So Jenny, thanks so much for joining us this afternoon. Over to you.
Okay, thanks very much. And yes, good afternoon to all the colleagues. And maybe just to say, these cases are all based on real life cases that I've had or we've had to discuss. I think it's always a good idea to be able to have the HIV hotline phone number in your back pocket and you know, just to get some advice, because sometimes the guidelines, you know, every case is slightly different, and sometimes if you just want to make sure, you know, and things like that. So I'm a family physician. I've been working in the Amatola District Clinical Specialist team, and we support 12 hospitals, 5 CHCs, and about 145 clinics in Amatola. And we've obviously get involved with a whole variety of programs, but the DCSTs were originally set up to support maternal and child health services. Okay, so maybe if we can just start with the first slide. I've asked Dylan to project because I've had some power outages and technical issues on my side. And I think the other thing is just I want us to, when you focus on PMTCT, a lot of the time you guys are going to get patients referred from a clinic or from the nurse, or even have telephonic consults. And I think we need to train ourselves to pick up certain things. We must be able to, you know, take histories and look for certain things in the history to try and help us. So as I was talking to Dylan a bit earlier, it's going to be quite difficult to have this too interactive. But what I'd like to do is at the end of the slide, if there's a question, if you can just take sort of 10 seconds to think of an approach that you would do. And obviously we're not going to go as it was an exam case that into every, you know, last little bit of detail, but just the sort of the main things to think about. Okay, so Sibongile, she's 35. She's a graph for para 3. She's had all her previous pregnancies were NBD. She's currently pregnant and she booked at 16 weeks. Her booking bloods were as follows: hemoglobin 11, RPR non-reactive, rhesus positive, and HIV negative. And she presents today now for antenatal clinic. And when she's tested, her HIV test comes back positive. On examination is fairly unremarkable, and the height of fundus is 20 centimeters. So how are we going to manage her further now? So this is really thinking about a patient who's newly diagnosed and she's currently pregnant. Next slide, please. So we obviously know that someone who is becomes HIV positive, seroconverts during pregnancy, the baby's at very high risk of a very high viral load, and so this baby is at very high risk. So we obviously want to start her on ARVs immediately, and the new guidelines are saying that even if you're worried about an opportunistic infection, you are still going to start the patient on triple therapy while you work the patient up for TB or any other opportunistic infection. So that has changed. Whereas previously, if you're worried about an opportunistic infection, you would then start a patient on AZT while you worked up the patient. And the main reason from what our colleagues have said at National is they found that many patients actually remained on AZT for inappropriate lengths of time, and this put the baby at further risk. So studies have shown that it's a balance between starting ARVs and knowing that you might have some iris and providing the maximum benefit for the baby. And so they felt that this is actually in the best interest of the mother and the baby, is to start ARVs immediately. So we're going to start the ARVs, and you're going to take your baseline bloods. You're going to obviously start currently on our guidelines, which says we start on TLD. And we would then continue with our screening for TB and any other opportunistic infections. And we would review her within a week. So the same proviso holds from the previous guidelines, that if there's anything in the history that might make you worried about using tenofovir, you would then rather use a bacavir. So for example, if there's 2 or 3 plus protein in her urine and her blood pressure is normal, or if there's some history of having surgery or renal problem, then you would rather use a bacavir. The only time that you would not initiate triple therapy when someone is pregnant and they test HIV positive would be if they are in a situation where, for example, you're worried that they've got a mass lesion, they've got a focal sign, they unconscious, reduced GCS, and basically you would be referring them. So there's any form of danger signs, you would then not, and that patient would obviously come to a hospital, and you would then consider either scanning or further workup, and then decide when to start the ARVs depending on what you find. So that would be the only time that you would not. When you look at the data, just some indicators, most of the time we should be having almost 100% ARV initiation in pregnant women, and you'll see across, if you look at some of the districts, and you'll see that is actually sometimes 90, 92, even 95%. And so there's clearly still a problem with initiating ART on the same day. We obviously know we can take into account someone's own preference, but there's a sense that healthcare workers are a little bit reluctant to initiate ARVs on the first visit, and that's obviously putting our babies at risk. So if you look at the next slide, you can see there that it's so important to start ARVs quickly and to get that viral load down, because it obviously reduces the risk of transmission to the baby. Okay, so next slide, please. If you look at the new guidelines, you'll see there that what has changed is that they've said that we need to do an HIV test at every bank visit. So basically every month, a lady should have an HIV test if she tests HIV negative at booking visit. So it was every 3 months, they should have an HIV test. And now if a lady books at pregnancy and she's HIV negative, she should have an HIV test every month. And we know that towards the end of pregnancy, often those bank visits are 1 or 2 weeks. And so just as long as we know that every month she's getting a test, and that's basically to make sure that we pick up HIV early and we're able to initiate treatment early. You'll see there as well that at the 10-week well baby visit, we're going to do another HIV test, and then we're going to test 3 monthly throughout her breastfeeding when she's breastfeeding. Okay, so that just comes from the new guidelines. Okay, so if we look at the next slide, so we initiate her on TLD, and remember the dolutegravir is very safe. Now the sort of current guidelines have come out have said that anything over 6 weeks of gestation is safe to use. And some of the recent data that are coming out from some of the large study sites, such as Botswana, are even suggesting that it's much the same risk as efavirenz for neurotube defects. So efavirenz is estimated to be at 0.1%, and at the moment, the estimation for dolutegravir is about 0.19% risk. So that risk has decreased, and so the WHO are much more confident in saying that we can use TLD basically in women of childbearing age, and those initial hesitancies have certainly been reduced. I have spoken to some people at the national, and they are in the process of putting out some kind of bulletin about that to be updated in the guidelines. I think COVID came along and that has been delayed. Okay, so after a week, we get the results. And I think it's important for us to remember that you don't want to get those results at the next bank visit, especially if someone's booking early. So it's important just to follow these results up. And it doesn't have to be a full abdominal examination, etc., but just to be able to eyeball them. Okay, so her results come back a creatinine of 90, a CD4 count of 500, and her hepatitis B is negative. Okay, so what are we going to do now, looking at those results? So remember, the creatinine is going to give us some idea of whether we can continue to use tenofovir. The CD4 count gives us an idea about use of cotrimoxazole and whether we need to look for a CLAT result. We also gives us an idea whether if it's very low, whether we should be on the lookout for unusual opportunistic infections. Sometimes there's a massive immune response, so sometimes there's quite a strong iris in patients with low CD4 counts. So we think about what we're going to do. If you look at those results, are there any red flags?
Can I just ask you a question there? Am I correct in saying that a gene expert would essentially form part of the booking or baseline results for any newly diagnosed HIV positive patient in pregnancy?
Yes, and we're going to come to that in a case. Yes.
Okay. Cool.
I'm going to come to that in one of the cases. Yeah, thanks, Dawn. Okay, so if you look at these results, if you go on to the next slide, you can see there that the guidelines are saying that because the GFR is not very accurate in pregnancy, because of your LICOR and your change in weight, we use an absolute creatinine result and not a GFR. And so if the creatinine is greater than 85, there should be caution about using tenofovir in pregnancy. And so what a sort of a pragmatic approach would be is to just maybe repeat that creatinine and make sure that when the lady came in, she wasn't having morning sickness or been vomiting a lot due to pregnancy. And if that second creatinine comes back and it's still raised, then you would want to stop the creatinine and you can substitute abacavir. And so you could use the Gemiva, which is the combination tablet of abacavir and 3TC, and the dolutegravir. And if that creatinine is very raised, certainly over 200, then you could discuss and dose adjust the 3TC. So there's a little bit of evidence that's starting to come out to say that we probably don't have to dose adjust as aggressively as what we were dose adjusting. Whereas previously we were quite quick to dose adjust the 3TC, but I think it would be a good idea to discuss that with someone just in terms of getting a weight and a height and looking at perhaps previous creatinines and trying to work out a diagnosis in that patient. So there's a whole workup then if the creatinine is abnormal, but just a sort of a red flag to say, switch the patient off tenofovir and then continue work up as we would usually do. And a lot of the time, this is related to high VAN, and these creatinines do improve with ARVs. Okay, so we are going to have a look at a case regarding TB screening, but just a reminder as well that we would not initiate TPT, which is your TB prophylaxis therapy, in a patient that's got a CD4 count greater than 350. So we'll come to that. So this patient's CD4 count is greater than 200 as well. So you would not need cotrimoxazole, and so you would just use your usual medication, your supplements in pregnancy, plus your ARVs. I'm not sure if there's any sort of a burning question. So I think just this case, just want to highlight about repeating your HIV test throughout your pregnancy if someone's HIV negative. If someone does test positive, to immediately start them on ARVs, to review the result after a week, those baseline bloods, and then just a reminder about the creatinine and change the patient off tenofovir if that creatinine is raised. Any questions or clarifications? You're gonna have to help me with hands, Dylan, if you can see any.
Yeah, I'll let you know. Doesn't
Okay,
seem to
cool.
be any questions at the moment.
Okay, so should we go on to the second case?
Yeah.
So Yolanda is a 34-year-old lady. She was previously on the TEE regime, but defaulted when her mom became ill and she had to go to Cape Town. And unfortunately, her mom passed away while she was in Cape Town. So she returned to the Eastern Cape, but she was very nervous about going back to her clinic because she had missed quite a few months. And when she finally went back to the clinic, she had already missed 3 menstrual periods and her pregnancy test was positive. So how are we going to manage Yolanda further? So this is really looking at a patient who's known HIV positive, who's been on ARVs and then defaulted. And if you think back to your non-pregnant patient, someone who defaults, the guidelines say that you restart them on their previous regime, and then you repeat a viral load after 3 months and see what that viral load is doing. So the problem with pregnancy is that if you waited, if you did that in someone who's pregnant, 3 months is a very long time to initiate someone on a regime that might be failing. So that's 12 weeks, and as we know, some women only present quite late for booking. And so the new guidelines are basically saying we need a more perhaps aggressive approach to manage these patients who have defaulted. So there are 2 options. There's sort of 2 pathways that we could follow. So if we can look at the next slide. So the issue here is that she is she's newly diagnosed pregnancy positive. She's a known HIV positive, and she's defaulted her ARVs. And so the guidelines say that if you need to look at her previous viral loads, and if the previous viral loads are LDL, then you can, and someone was on TEE, then you could initiate them on TLD. Okay, so if we go on to the next slide. Okay, and the next one. Sorry. Okay, so this is the diagram from the guidelines, and you can see there that if someone was previously on ART, if they were on TEE, and you look through the folder or you look on TrackLab, and you find that the previous VLs were LDL, then they're pregnant now, then you take a viral load at baseline, and you would repeat the viral load after 3 months, but you would reinitiate this patient on TLD. Okay, so if you go to the next slide, the reason for that is that we know that dolutegravir needs an active NRTI. It needs a bodyguard. And so if you think about someone who was previously on TEE and their viral loads were suppressed, it means that that regime was working, and we suspect that there's not likely to be resistance, maybe a little bit to 3TC, but we are pretty sure that the tenofovir and the 3TC were intact. They were basically active. And so the idea is that if you want to use dolutegravir, you must make sure that there is an active NRTI to basically be a bodyguard. And so if someone was on TEE and their viral load was suppressed, then we can fairly confidently initiate TLD, because we're sure that those NRTIs are going to so-called look after the dolutegravir. So someone like this, if they present, we're going to treat them exactly the same. We're going to do your pregnancy booking bloods. You're going to take blood for CD4 count and your viral load. And because we're going to initiate tenofovir, we're going to take a creatinine. We're going to do a hepatitis B because she's now pregnant. And we're going to initiate the TLD and follow the guidelines through that. So if we go on to the next slide, We're going to start her on TLD, and we're going to do TB screening. So and screening for other opportunistic infections. So the next slide shows the new TB screening in pregnancy. So you can see there that if you can click, I think it's twice still to get the non-pregnant. Yeah, so if you can see there, TB screening in non-pregnant non-pregnant females and males. We're still going to use a TB screening tool, and we're going to then, if someone doesn't have any TB symptoms, we would be able to initiate them on TPT as long as there are no contraindications, for example, liver disease, etc. So what has changed now is TB screening in the pregnant lady, and what you have there, if you can click, that's right, and one more click. So you can see there that they're saying we're going to use the TB screening, the questions, and we're going to take a gene expert, and we're going to look at the CD4 count, and one more click, and then we're going to decide about TPT using all of those factors. So for all HIV positive pregnant women, we need to do TB screening. We're going to have to get a gene expert on all of those women, and we're going to look at the CD4 count. And if the CD4 count is less than 350, then we're going to initiate TPT. But if the CD4 count is greater than 350, then we're not going to initiate TPT. So as you know, I think this is about there's been a couple of variations when the guidelines first came out. And what the study showed is that there was an increased risk in the arm in the studies that of an increased risk of miscarriages and low birth weights in the arm that was taking TPT. But as you know, the risk for maternal illness, especially getting TB, is very high, especially with low CD4 counts. And so they had to try and strike a balance between when is it beneficial to give TPT, so you basically prevent the mom from getting TB, and then you prevent serious illness in the mother and adverse and perinatal outcomes. And when is it almost harmful to give TPT, because the mom's immune system is actually quite strong, and when you give TPT, then you actually pose a risk to the baby. And so sometime last year, then this guideline actually changed slightly and they raised the CD4 count to make it 350. So what that means is if someone is on TPT and they then fall pregnant and their CD4 count, for example, is 400, they would actually stop TPT for the duration of their pregnancy. And then the TPT would be reinitiated at 6 weeks postpartum. The guidelines recommend that a person gets 1 year of uninterrupted TPT if you're HIV positive. And so if someone had a few months of TPT prior to pregnancy, falling pregnant, then you would have to restart the TPT postpartum, and they should then have 1 year of uninterrupted TPT, which might mean that they actually get more TPT than if it was broken up during the pregnancy. So I think this is where sometimes the note taking is a little bit confusing, and something that we need to improve, especially explaining to a woman who might have been started on TPT why her TPT is being stopped during pregnancy, and explaining that this might be reinitiated after the baby's delivered. Okay, so GXP, so there have been some questions around getting a sputum from someone who isn't coughing. I think it's a valid concern. Someone in a national training said you can get a sputum out of anyone if you take a couple of deep breaths and you give a real belly kind of cough. I'm not totally convinced that that is true. I think the principle, though, is to try very hard, and the reason is that they found that the symptom screening was a little bit inaccurate in pregnancy, and they felt that they need to try and improve that by getting a GXP. So I think it is difficult. I think if you if someone really can't, and you've tried, you should just note it down. But you certainly should try and get a GXP from HIV positive pregnant women. Okay, next slide, please. Okay, so we're going to reinitiate ARVs, and it's going to be TLD. We've taken our baseline bloods, and when she comes back, these are the results. So she is now pregnant, and she's been reinitiated on ARVs. Her HB is 11, basically her booking bloods are normal. Her SIVA count is 400. Her now baseline viral load is 25,000, and her GXP is negative. So question, are we going to start TPT? And when would you next repeat her bloods? Okay, so we've just spoken about the TPT story. So with a SIVA count of 400, 400 is greater than 350. So we would not initiate her on TPT, and we would only initiate her then on TPT postpartum at 6 weeks. And then are you going to, when are we going to repeat these blood tests? So the guidelines say that we're going to, you can do the next slide, please, that we're going to repeat the blood after 3 months. So because we've initiated her on a tenofovir containing regime, we would do a creatinine, and we would do a viral load after 3 months to make sure that that VL is suppressed. Okay, next slide, please. So Yolanda is now 30 weeks pregnant, and she's been on TLD for 3 months. Her 3-month bloods are VL, LDL, and a creatinine of 79. Okay, so now when are we going to repeat these bloods again? Okay, so the guidelines now say, if you can turn to the next slide, please, that basically the next viral load with Yolanda is going to be basically at delivery. So when we say delivery, it basically means postpartum. Not literally in the labor ward. So there's been a lot of discussion around this. And when we've spoken, so this is really a public health approach, because the national people at national are saying we never know when someone's going to deliver. And so if we want to try and get a viral load just before someone delivers, if we say 36 weeks, some people might deliver at 41, 42 weeks. If we say 38 weeks, some people might deliver 37 weeks. It's very difficult to try and have a standard. And I think I've heard that there's only 10% of women deliver on their due date. And so what they said is that there's only one common point for all women who are pregnant, and that's delivery. And so the rationale is to say we need that 186 Rand to count the most. And so we need to do a viral load that's uniform, and the only uniform time is basically just after they've delivered. And so we're going to use that viral load to then decide about going forward into the postpartum period. And a lot of people feel very uncomfortable with this decision. But I think you have to think of it perhaps more from a public health point of view, to try and pick up warning signs throughout pregnancy. So as soon as you can certainly do a viral load if you're worried. But if you're just doing a viral load to reassure yourself, then you have to think about the money that's been taken for that viral load. And we do have a sort of a finite budget. So for example, if you find that there's an opportunistic infection that someone who's pregnant is exhibiting, or you're worried that pill counts aren't really matching, you can definitely do a viral load anytime during pregnancy, because you are wanting the viral load to act on. If someone is attending their appointment dates, their pill counts are correct, they don't have any signs and symptoms of an opportunistic infection, if you're following the guidelines, you don't have to do viral loads outside of what the guidelines are stipulating. So if you look at that page, and I'm sure you've read it now, we would do, if in an HIV naive person, we would basically do the first VL at 3 months. So we don't do a VL at baseline. They are doing that in private. but we would do our first VL at 3 months. In a woman who has previously been on ARVs, we would do a VL at baseline, and then repeat that VL at 3 months. And if the VL is LDL, the next time that you would repeat that VL is actually delivery. So that means someone delivers, and that next morning you take a vial load. So we're not taking a vial load actually in the labor ward, just that we clarify that. Okay, next slide, please. So the next time we're going to do a VL in Yolanda is basically at delivery. And next slide, please. So Yolanda continues to take her TLD well throughout pregnancy, and there are no complications, and there's no reason for you to worry that things are not going okay. So she goes into labor at 38 weeks, and she delivers a healthy baby girl, the birth weight of 3.5 kilograms. Okay, so how are we going to manage Yolanda and her baby now? So now what we have to think of is Yolanda's baby a high risk or a low risk baby? And that is basically going to be dictated by the viral loads taken through her pregnancy. So we have to look at when the viral loads were taken and what the viral loads were. So if the viral load, her latest viral load was taken within 12 weeks of delivery, and that viral load is suppressed, then she's classified as a low risk. If that viral load was LDL during pregnancy, but was taken outside of 12 weeks prior to her delivery, then she's actually considered high risk, because she doesn't have a VL within 12 weeks of delivery. And this is where sometimes there's a little bit of confusion, because you see that there's a viral load that's suppressed during a pregnancy, and yet she's classified as a high risk patient, simply because of the time period of when it was taken. The other thing is obviously to look then as well whether the VL was suppressed or whether it was raised. So looking at the next slide, we're going to do a vial load at delivery. We're going to make sure that we have a barcode that is placed on her discharge summary, or sometimes patients have little handheld books. We're going to encourage and support breastfeeding. We're going to discharge her with 2 months supply of ARVs, which is also new in the guidelines. And one of the reasons for this is that they found a lot of the time after someone's delivered, a person would go and take the baby to visit Granny and Grandpa, and they would take the baby to another town to visit some other relatives. And with all the traveling around, patients often miss their date for ARVs. And so it's been felt to give them 2 months of treatment. What is important is to make sure that this is communicated, that new date is communicated with the clinic at the postpartum visit, because sometimes these patients are marked as lost to follow because they are literally traveling around the countryside with their baby and they haven't returned to their clinic for their follow-up date. And it's also important when a patient is discharged from the hospital to write a date to return for their ARV collection, and not just times 2 months, because sometimes the dates are a bit, months are a bit of confusing to think about, and so it would be better to write to come back on the 15th of March rather than just times 2 months. We're going to give a date for postnatal visit, and as you know, we generally have very good 6-week 6-day postpartum follow-up visits. And we're going to then, at that 6-day postpartum follow-up visit, we're going to check that delivery VL. So it's important that the nurses have access to TrackLab or some form of looking up that result. And it's important that there's a barcode. As you know, it's sometimes difficult with spelling and handwriting to look for that result. So there are 2 problems, sort of public health implications with this. The one that we've heard from big centers, and we've heard from Gauteng, is that there's nervousness that the clinics are not going to be able to find the viral load result. And so basically all babies are discharged on AZT and nevirapine to almost cover that. So they basically treat everyone as high risk and pretend that a 6-week follow-up, a 6-day follow-up is not going to happen. The other sort of side of that is if you find that the hospital is nervous that the clinics are not going to do a job, and they call everyone back to the hospital for a 6-day postpartum follow-up. And that actually breaks the continuity of care, and in terms of reconnecting with the clinic after delivery. And as you know, the majority of women receive antenatal care at primary healthcare level, and the majority of babies receive the EPI visits. And so it's important to strengthen those processes and not to try and break them up. And so as family physicians, you will probably be involved in systems and trying to improve systems in wherever you're working. And so it's important to provide support to try and make sure that those systems are strengthened, and that, for example, when a clinic refers a patient to the hospital, that the dates of the viral loads are written, so that it helps the hospital to know whether this patient is a high risk or low risk. And in the same breath, it's important that the hospitals give the right information to the clinics, so that they're able to follow up these mom-baby pairs appropriately. Okay, so if the viral load of Yolanda at delivery comes back as LDL, then we're going to continue to give the baby MVP, because she continues to be classified as low risk. Okay. In terms of her baby, obviously the baby's going to get a birth PCR, and once again you're going to put that sticker in the Road to Health book. Nurses and patients seem to prefer that the barcode gets put towards the back of the book in those blank pages, and not actually, some people don't want it to be put onto the actual PMTCT page. I think if you just write the date and you put the sticker there, most people will know what it is. And this baby would be classified as low risk because her last VL was taken 8 weeks prior to delivery. And so the baby's going to be discharged on MVP. We're going to give a 6-day follow-up, and we're going to support breastfeeding. Okay, so if we go to the next slide, it's just from the guidelines, and just saying that all HIV positive pregnant women would have a viral load at delivery, and that's going to help us to adjust the prophylaxis for the babies going forward. And then what's also new is that women are going to get a 6-month viral load during breastfeeding. So that is also aligned to some of the EPI visits. So if we just look at a few slides from the guidelines, and I'm sure you've seen these, the next slide, please, you'll see that the strategy for, you can click 1, 2, 3, 4, it's about 5 or 6 clicks. You can see there that the strategy for getting a healthy, well baby, one more, Bill, is, and one more, is to make sure that the mother's viral load is suppressed throughout pregnancy. So we want to diagnose women with pregnancy early and HIV early. And our second strategy is to give appropriate post-exposure prophylaxis. If we go into the next slide, you can see there our definition of low risk and high risk. So low risk is basically a viral load that is less than 1,000, which is done within 12 weeks of delivery. And the baby, a high risk baby, is if the viral load is greater than 1,000, or if there's no viral load available. So you may well find that a clinic took blood, but for some reason you can't find it on TrackLab, or there's no result in the folder, and then you should treat that lady as basically as a high risk until further viral load is repeated. So if you look at the next slide, our low risk babies are going to get NBP for 6 weeks, and our high risk babies are going to get a minimum of 12 weeks of NBP and 6 weeks of AZT. So I've spoken to some people from National. What happens if the viral load of the mother is, for example, 600 or 500? In the guidelines, we see these 3 categories the whole time of VLs less than 50, VLs between 50 and 999, and then viral loads greater than 1,000. And they basically said that a viral load less than 1,000 is a very low risk of transmission, and so that's why this category is basically less than 1,000 or greater than 1,000. Okay, so we know now that we have to look at the viral load during pregnancy. We have to look at the timing of the viral load. And then all HIV positive pregnant women get a viral load at delivery, and they are discharged according to their viral loads during pregnancy. But then that risk is categorized at the postpartum, a 6-day postpartum visit, and then it can be changed. Okay, I'm not too sure if there's any questions or comments. Everyone's still fine?
Nice.
Okay, so let's go.
Very clearly, Jenny.
Say again.
You're obviously doing a great job.
Or everyone's asleep. Okay, so let's go into the third case. Okay, so next, so Nonhlanhla is a 30-year-old lady, and she's known with HIV. She was taking TEE, and then that was changed to TLD during pregnancy. So we know in the guidelines that if a viral load is less than 50, then you can make a one-drug switch, and you can switch someone from TEE to TLD. So we know that her VL must have been suppressed. She has an uneventful delivery, and her baby was discharged from the hospital on NVP. Okay, so her baby was basically classified as a low-risk baby. So Nonhlanhla goes to the clinic on day 5 for her postnatal visit, and when her delivery viral load is looked up, the delivery viral load is 22,600. Okay, so how are you going to manage this situation now at the moment? Okay, so we can just think back to what we were talking about. This is an example of someone who you're going to need to recategorize the risk. Okay, so next slide, please. So what we do in all of these situations is we always do the ABCD. And I'm sure people are very sick and tired of hearing this, but it is a useful structure to follow. And, as you all know, looking at adherence issues, et cetera. I think what's specifically important in pregnancy is looking around disclosure issues and mental health. So I've had a patient where the partner arrived back suddenly from the mines in November, and she had not disclosed to him. She was pregnant at the time, and she stopped her ARVs, and she delivered in the middle of January, and her baby was HIV positive, PCR positive. And when we asked her about this, she only told us later that she didn't know how to handle that situation. So I think it's useful throughout pregnancy to keep discussing with the lady about her immediate support system, her family, because a lot of the time someone who's pregnant might move to be with a partner, they might move to be with other family members, and sometimes that environment is different to their home environment. I had another patient who was not able to disclose to the family, and felt that she was a little bit at risk of being thrown out onto the street, literally. And so whenever the partner returned, she would leave her treatment with a neighbor, and she would wander over in the late afternoon and go and have a chat and swallow the tablet and then come back again. So I think we have to be quite realistic about domestic violence, about disclosure issues, and realize that a woman feels very vulnerable when she's pregnant, especially if she has smaller, toddlers or children. And I think we have to be sensitive to that. So I think we have to sort of ask those open-ended questions so that someone feels comfortable to then express their situation, and then to be creative in trying to ensure that someone is able to take treatment. The other issue that comes up in pregnancy, and specifically more postpartum, is postpartum depression or mental health issues around sometimes precipitating depression, or maybe there's a home circumstance that having another small child just brings that to the fore. So I think the A part is quite important, and we need to just take a little bit of time with these patients. And why I say that is that often these patients are referred to the next level, and they arrive on your doorstep from the clinic, from the nurse. And it's very easy to want to rush into perhaps changing treatment, etc. So we need to just remember that this patient is on TLD, and we know that dolutegravir is a very robust drug. And so any raised viral load within the first 2 years is very suggestive of poor adherence. And I think that's the little trigger that we need to kind of think, and we need to then have the right approach to try and get out what might be the problem. Okay, so we go to the next slide. So someone who is this is the algorithm for someone who's pregnant, which we're going to follow if postpartum, if someone is breastfeeding. So a lactating pregnant or lactating woman is treated the same in terms of repeating bloods and viral loads as a pregnant lady. And so this comes from the new guidelines, where you'll see on the left-hand side, if a viral load is between 50 and 999, we're going to repeat that viral load in 8 to 10 weeks. And they put it within that range so that you can try and match it to a bank visit. So we don't want women to spend unnecessary time at clinics coming for blood and then coming back for a bank visit. So basically within 2 months, we would like to repeat that viral load. If a viral load is greater than 1,000, we're going to want to do that within 4 to 6 weeks. And once again, you can think of the postpartum, the lactating postpartum woman, to try and fit that into EPI visits, those 4 to 6 weeks. And you can see there how the algorithm pans out. So with our patient now, if you can go to the next slide, please. You can see there that when you start questioning Nonhlanhla, she said that she was very
Sorry, guys, we seem to have lost Jenny there. Let's just see if we get her back.
Okay, so suddenly now we reclassify her baby as high risk. And Jenny, I think it's important to...
There. You cancelled out for a few seconds. I'm not sure if you just want to rewind 1 or 2 sentences.
Okay, I see my Wi-Fi has just come back on, so I probably was changing between networks. Okay. Okay, so right, so the baby is now going to be classified as high risk because we have a delivery viral load. And so it's important to then explain to the mom and the caregiver what that means, and to show we're going to now add AZT, and we're going to also extend the duration of the nevirapine. And once again, I found it useful to write the actual date. So look on your calendar and say AZT until and write a date, and NBP until at least and write a date. Because when these patients come back and forth, you start to forget when they started, etc., etc. So the guidelines now say we're going to initiate AZT for 6 weeks, and we're going to extend the NBP for a minimum of 12 weeks or until the mother's viral load is suppressed. And we know that according to the guidelines, the next time we would repeat this viral load is after a month, 4 to 6 weeks. It will give us chance to act. It will give us chance to even take bloods after another 4 weeks. And so that's why that 12 weeks is there, so that we have chance to try and sort this viral load out. Okay, and we're going to continue to support breastfeeding. And I think especially now in the post-COVID period, or in the COVID period, there's huge financial strain. Many people have lost work. We also have many parts of the country in the province that are struggling with water. And so it's very, I would say I almost want to use the word dangerous to recommend formula feeding in someone that doesn't have reliable financial means, including reliable water sources. So that's why we're giving the NBP and the AZT, and we're obviously going to continue to support the mom and to try and get her viral load down. Okay. Okay, so next slide, please. So the next time we're going to see the mom, so obviously we're not going to go into all the details, but for the patient in the clinic, we're going to consider, are there thyroid, perhaps their thyroid issues. We're going to look at HB, did she have postpartum hemorrhage, all of those things, that what might be causing her tiredness, is she depressed, what is her social support. Okay, so then we're going to ask you to come back. So the next EPI visit would be a 6-week visit, so we're going to ask you to come back then with the baby. And it's important to say that we want the mom to come back then as well, because sometimes the granny will bring the the baby, and then we don't see the mom. Okay. So if you think, then what are we going to do at this next visit? So if we divide it up into the baby and the mom. Okay, next slide, please. So we think about the mom. She's now postpartum, she's breastfeeding, and she has had a raised viral load, which means we need to do our ABCD, we need to pill count, and we're going to repeat that viral load. Okay, and we're going to do mental health screening and support. In terms of the baby, it's an EPI visit, so we're going to check on weight and height, head circumference, check the milestones. We're going to give the 6-week immunizations. We're going to start cotrimoxazole, and we're going to stop the AZT. We're going to continue with the nevirapine, and then we're going to write a date for the 10-week EPI visit. Okay. So in terms of checking, so in checking this this baby, remember, any time that you're worried about the baby, we can do anytime we can do a PCR. So the next EPI visit, or the next time we would do a PCR, would be at 10 weeks. But if this baby is not growing, if there's any signs of any infections, if the mom has any evidence of TB, we'd obviously want to try. We'd want to do a PCR on this baby to try and pick up any infection. But according to the guidelines, the next time that we do a PCR, if you go to the next slide, you would see there that we do a birth PCR. The next time we do a PCR would be 10 weeks. Okay, so if you click a couple of times still, 1, 2, 3, yeah, that's great for now. So they've taken away the 6-week PCR, and they've also taken away, there was a funny 18-week PCR for those people who were on the NBP for extended period. So I think, as you know, the NBP was masking some of the PCR results, and so that's why they felt you need to have another PCR, but nothing really happened at 18 weeks. And so what they've done is that they put a 6-month PCR in. And so there again, just to reiterate, if a baby is showing any signs or symptoms that you're worried that they might have HIV, then you can do a PCR anytime between 10 weeks and 6 months. But the 6-month PCR is basically there to try and maybe catch any babies that might have been on an extended NBP, and just to try and ensure that we have another system for detecting early HIV. What is new in the guidelines is that all toddlers, irrespective of the mom's HIV status, are now going to have an HIV test at 18 months. So some people feel that this is a little bit uncomfortable to ask a mom to do an HIV test on a baby when you know that the mom is HIV negative. But I think the messaging is we do a whole lot of things in EPI, and it's a standard package of care. And one of the things that we're going to be doing in future EPI visits is an HIV test. So it's a rapid test. It's just a rapid ELISA test, and we would do that at 18 months on all on HIV exposed and HIV non-exposed. The new guidelines say that if the 18-month ELISA is positive, we would then confirm that with a PCR. And I'm sure you've seen in the guidelines that between 18 months and 2 years, they found that there are actually quite a few maternal antibodies still in the baby. And that's why they've decided to confirm with a PCR during that time. If the baby's over 2 years, then you would confirm with another rapid test, HIV test. Okay, so then just a reminder that we would still do a PCR 6 weeks post cessation of breastfeeding, and we would then do a PCR at any time if you're worried about the baby or the mom becoming symptomatic of forward OI. So if the mom's viral load suddenly increases, the mom becomes sick or develops TB, then you would immediately want to do a PCR on the baby. And the same for the baby. If the baby starts to lose weight or you're worried about an opportunistic infection, you would do a PCR. So those are just the standard PCR times. your birth PCR, your 10-week PCR, 6-month PCR, and then your rapid test at 18 months for all toddlers, basically, and then a 6-week PCR post-cessation of breastfeeding, and then at any other time that you're worried. Okay, any questions?
Jenny, I think maybe we should leave the last case with it being nearly 6 o'clock, and
Yes.
obviously we'll be able to share that this presentation with everyone, yeah, maybe if there are any questions that arise, the people can message you or message on the group. But are there any questions on the first 3 cases that we've done?
Hi, mine is with Yolanda. The Yolanda case. You gave us a scenario where she comes and then her viral load was initially suppressed. Now, what if she had defaulted and now she comes with a high viral load? Do we switch her to second line regimen or?
Okay, so I think that the principles are always, if you have a high viral load, then you always want to do your ABCD and you want to repeat it. And so it depends what the viral load is. If it's less than 1,000, you're going to repeat after 2 months. If it's greater than 1,000, you're going to repeat it after a month. So I think we don't act just on one viral load. I think that's the first thing. And then the same sort of principles. If someone defaulted treatment, look to see what their treatment was previously. If they defaulted second line, so if someone was on an aluvia-based or dopinavir-ritonavir-based regime and they defaulted and they come back, you obviously have to restart their previous regime, which is the dopinavir-ritonavir-based regime. If someone was on TLD and they defaulted, then you would restart them on TLD. If someone was on TEE, then you would look at the viral load and decide if the viral loads were previously suppressed, then you could immediately restart them on TLD. We didn't get to the case, this is this case now, if the viral load was not suppressed, and Dill, I'm not sure if you can go into slide 35 just to show that if they had defaulted previously and the viral loads were not suppressed, then you would actually start them on AZT 3TC dolutegravir. So in a sense, you're starting them on a so-called second-line regime. And that, again, is to make sure that there's a bodyguard for the dolutegravir. So you've got an active NRTI. So looking at your Yolanda, who had, during that time period between the end of pregnancy and, starting and postpartum, maybe she has defaulted, but you would just put her back onto the TLD then, because that's the best regime for her in that situation. So I think the message is, dolutegravir is a very robust drug. We don't want you, to get panicked and try and do other things. We just got to be very, very methodical and very consistent. A high viral load, ABCD, find a reason, support, repeat the viral load according to the guidelines, look at that viral load, support, etc. And we know that dolutegravir, if dolutegravir is in the regime, then we don't change within the first 2 years. We don't get genotyping, we don't do anything. We've just got to consistently try and find out, what might be interrupting. And this is sometimes the frustrating part. And you'll see one of the cases that has been a case that, I'm sure you can all relate to, where the viral load doesn't go down because the lady or pregnant lady is not taking the treatment, or she's throwing it away, or she's and those are the difficult cases to really get to grapple with. And one of these slides you'll see that I put, how does that make you as a healthcare worker feel? And we often feel frustrated, we feel desperate, we feel depressed. Sometimes the nurses say they want to ship this patient off to another clinic because they're worried that this baby's going to come back PCR positive and it's going to be so-called their fault. So yeah, I think that, just be methodical and just think the whole time, what are you doing for the baby? What are you doing for the mom? And remember, you can continue the NBP beyond 12 weeks, to make sure that you are while you're trying to sort the mom's VL out. And I think just the message as well, you know, just be very, very careful about putting a patient onto a dolutegravir-based regime if you don't have an active NRTI. So don't be tempted if someone's got a raised viral load. Don't be tempted to go from TEE to TLD and think, oh, that's going to solve the problem. You must have an active NRTI. You must have a bodyguard. And you've got to look, when you write that with that pen, you've got to say, what is my active NRTI that's going to protect my dolutegravir? And that's why this slide basically says, if you're not sure, rather give AZT3TC dolutegravir. So you know you've got your AZT as your bodyguard for your dolutegravir.
Cool, awesome, good question. Awesome, Jenny, thank you so much for that. That was really, really informative. Yeah, I think that's going to be incredibly helpful and hopefully a useful resource rather for people that are going to be dealing with these kinds of cases. It's incredible how frequently these guidelines are changing. So you really need to be on the ball in terms of keeping up with all the latest changes. So it was really helpful to see all the updates. Yeah, so guys, I think we're going to stop there. Yeah, like I said in the message, we will post this presentation in the shared Google Drive folder. So if you want to take a listen to it, or if you didn't get to be here for all of it, then feel free to download it. And yeah, we'll be doing the next tutorial next week on Wednesday at 1 o'clock. We're going to take a bit of a break from infectious diseases, and we're going to be having a session run by Dr. Kevin Passio, who is a family physician working in the emergency unit at Livingston Hospital, who's going to be going through some cardiology with us. So feel free to join us if you'd be interested in that. Yeah, thanks so much, Jenny. I think we're going to call it a day.
Thanks, everyone. Yes, great to be here.